Your Excellency,
السادة الحضور، برجاء الالتزام بمقاعدكم. سوف تبدأ الجلسة الآن.
Ladies and gentlemen, please remain seated. We will start now.
Which in some ways I kind of like. It's 9:01. We should be starting. That's me. I mean, I'm not Syrian. I'm an American, but I grew up in Syria, so I don't know which one I said.
Good morning, ladies and gentlemen. Thank you for joining us today. We welcome you to the third day of the Global Congress on Population Health and Development, a momentous event hosted by the Ministry of Health and Population under the esteemed patronage of His Excellency President Abdel Fattah al-Sisi. Today, as we gather once again, we embark on a journey of exploration and discovery, delving deeper into the critical intersections of population health and development. Our discussions will bring together experts, visionaries, and thought leaders from around the world. As we begin, I want to express my anticipation and excitement for the sessions ahead, and I'm sure you'll enjoy and benefit from these enlightening discussions. Let's get started with our first panel for today.
Thank you, Yasmin. Good morning, distinguished guests, ladies and gentlemen. We hope you had a good rest last evening and are settled into the conference. So for this morning, we have a very interesting session titled Primary Healthcare, a Cornerstone for Development. And we all know that primary healthcare is a whole of society approach to health that aims to ensuring the highest possible level of health and well-being and their equitable distribution by focusing on people's needs and as early as possible along the continuum from health promotion and disease prevention to treatment, rehabilitation, and palliative care, and as close as feasible to people's everyday environment. For this session, we will be looking at a couple of areas, and I know that we also have other PHC sessions later today. For this session, we will be focusing on strengthening primary healthcare systems and improving community-based health services, innovative models and best practices in primary healthcare delivery, promoting comprehensive sex education and youth-friendly services, midwifery as a best practice to improve reproductive health. And we have with us our distinguished speakers. And our first speaker is Dr. Bernardo Martorell, who is the coordinator of the Health Reform Ministry of Health, Chile. So over to Dr. Bernardo to present to us on the strengthening primary healthcare systems and improving community-based health services. So over to you, Dr. Bernardo.
Thank you, Shirley. Good morning, colleagues and friends. It's very nice to be here with you. And I would like to share with you our experience from Chile, a faraway country. And hopefully our experience in primary health care serves as a point of reference for a conversation. Of course, every country is different, but it's always helpful to have a new perspective. Just to start, health is the greatest wealth of a nation. Health is the basis for all other activities, for economic activities, for social activities, and it's very important for us in the health sector. Most of us that are here in this audience probably agree with the importance of health, but many times we have to convince ministers of economy, ministers of finance, and other sectors about the importance of health. So to just say that health is the greatest wealth of a nation is an important statement. Primary health care, on the other hand, has shown consistently to be the best investment for improving health in different countries. Studies, international studies, have shown that primary health care increases equity, increases efficiency, and increases satisfaction and quality of health care. It's just, as such, it's a cornerstone for development, and overall, we know that it improves health by 30%. So it's like a universal vaccine that improves health for everyone. On the contrary, systems based on specialist care can be hazardous. We know by studies by Johns Hopkins University that medical error is the third leading cause of death in the United States. Chile. Chile is a small, however, very long country. We have the driest desert in the world in the north. We're similar to Egypt in that. And fjords and glaciers in the very south. The total surface is 76% of Egypt's surface. However, the 4,000-kilometer long decentralizing primary health care. This has strengths and weaknesses. The main strengths we see today, after many years of decentralization, is that we have today new allies for primary health care. These political leaders in each municipality of the country today is a stakeholder of the primary health care system. So every year we see how they mobilize political will to increase budgets for primary health care. Secondly, this shift to local governments of primary health care keeps primary health care far from hospital concerns and also helps to avoid the temptation, which is always there, to transfer resources from primary health care to hospital care. And currently we also see new opportunities arising with this municipal administered primary health care, which is that we can start to integrate social care and other intersectorial actions to health at the local level, which of course is fundamental for impacting health. So we're starting to see a real territorial model of health arise. However, not everything is easy. Of course, we have municipalities or local governments that do good jobs and that are very efficient, and we have municipalities that don't do such good jobs. So that some equity concerns start to arise. So it cannot be a full decentralization of administration of primary health care. And so with the years, in 1995, we implemented a per capita payment system. So the per capita payment system, we moved from a fee-for-service to a per capita payment system, helps to equalize financing across the board in all the territories of Chile. In that same legislation, we also standardized salaries and incentives for the career of primary healthcare workers. The per capita financing has some adjustments based on territory, if it's rural, if it's urban, based on wealth, if it's an impoverished area or if it's not an impoverished area, and isolation. Through the years, the per capita has been proven to be a robust payment mechanism. However, it does require some adjustments, such as adding incentives, balancing with vertical programs, bundled payments, and fee-for-service and very specific health actions. One of the most controversial subjects is the costing of the payment level. We do not have a formal costing process, and every year the per capita payment level is a controversy of all stakeholders. These are ongoing challenges. So in this context, primary health care has fulfilled three distinct roles through the years. Firstly, as the gatekeeper to the secondary and tertiary levels of care. Overall, this works well. However, we are missing better integration with the secondary and tertiary level, leveraging network integration potential. The second role has been to keep people healthy through different programs. Successive governments add new programs that address different issues, adding layers of programs to primary health care, such as family planning with midwives, adolescent health, mental health, cardiovascular health, elderly programs, and many more programs that have been added to the system over the years. This has made the system a bit more complex, and monitoring sometimes is somewhat incomprehensible. So it's very important as a challenge to simplify monitoring and overall quality control. The third role of primary health care has been that of a platform where any innovation, any best practice, any new intervention based on the evidence can be quickly scaled up through the entire country in a more or less uniform manner, reaching the entire population. This has been very important, for instance, when we had the pandemic of COVID. The COVID vaccination was very quickly delivered through the primary healthcare network. Similarly, in the 90s, we had respiratory diseases that were addressed in primary healthcare, and we with that decreased infant mortality very quickly. Today, people-centered care for chronic conditions is being also scaled up. And of course, population strategies and participation of social communities also is part of our primary healthcare system and is very important for social cohesions. So some lessons learned from primary healthcare in Chile. Firstly, adding new actors to primary healthcare, such as local authorities or as administrators, helps to empower primary healthcare in face of other demands on the national budget. Secondly, you must strike a balance between decentralization and central control, monitoring and planning. Thirdly, these local elected officials can embody a territorial model of health, integrating social and environmental determinants much more effectively, thus integrating other essential public health functions that help face, for instance, problems like climate change. Fourth, the per capita payment system is robust. However, it must be constantly costed, adjusted to represent the cost of delivering primary health care in each locality, linked to incentives and blended with other mechanisms. Fifth, adding new types of workers to primary health care with training in prevalent health conditions is an efficient way to escalate effective care. Six, modern information systems with universal and enforceable standards is a huge opportunity in monitoring activity, quality, and integrating health networks. This is still a challenge for us today. And lastly, community engagement with people and communities in command of their care and services is fundamental for developing and building health. As a result of improvements in primary health care over the years, recent surveys in Chile have shown that primary health care centers are the #1 institutions that the population trusts. We hope to continue strengthening this path of creating health with our communities. And just to give us a small idea of what we're working on today, because of course we have many challenges in primary health care, our next steps is to go forward with universal primary health care so that primary health care can be available for everyone in a territory, regardless of what kind of insurance they have. However, when we say universal, we don't only mean that people can register for primary health care. We want to improve quality so that people want to register and that primary health care is the first option for everyone in our country, both poor people, middle income people, and high income people, so that we have and we move forward a true universal health system. Thank you very much.
Thank you, Dr. Bernardo, for your interesting presentation, for also highlighting the importance of investment in primary healthcare, adding new actors, and also having a balance between decentralization and central control. Also interesting to hear how you've integrated areas such as adolescent health, mental health, midwifery into your programs, as well as the community-based services that are so well integrated within the program. So we'll be happy to talk more with you later, and if the participants are interested. And we go over to our second speaker, who is Dr. Deepak Batra, who is the head of public health, Middle East and Africa IQVIA, who is also supporting the OSRA program. Over to you, Dr. Deepak.
Thank you, Shirley, and good morning to all the esteemed guests to the presentation, also to my fellow panelists. The topic that I'm going to talk about from a primary care perspective is the digitization piece of it, right? Our colleague, Dr. Bernard, has very beautifully captured what Chile has done. In a way, that's how primary care should look like, right, in most countries. I know a lot of countries, including Egypt, has made a lot of progress towards that, but ultimately the primary care should have certain attributes, things such as obviously the provision of the primary care services as we have it today, but then also getting into prevention, behavioral integration, medication management. The whole population health management piece is picking up a lot of focus these days, especially from a primary care perspective, because while you want to provide the best care and quality, but at the same time you want to ensure that the costs from a healthcare perspective are controlled, right? Having an easy access. Another important point about primary care is that how can we ensure that the linkage between the various levels of care, and primary care probably plays the most important part here, is from the community to the primary care and then up towards the secondary and tertiary care. How are those linkages maintained? How can you provide care to the closer to the patients or closer to the caregivers? So all of these are very important attributes, and fundamentally there's something shifting today in the healthcare scenario, as you would see. You can see more new vaccines are coming up, right? They are in the pipeline, or they are getting introduced. The diagnostics are getting more closer to the patients or where the populations live. You have more point of care testing, you have more rapid testing or self-testing which is getting promoted. And all of this would mean that primary care will, if anything, play a much, much greater role going forward. And none of these will be successful, new vaccinations or new diagnostics can be successful, unless you have a very solid base of primary care through which these can be administered to the population. So the primary care fundamentally also has to look different from what it is doing right now in the next few years. And that is where we feel that digitization of all of these components that you see will play such a major role, because that can make all of these immunization programs, the behavioral change programs, the community programs much more effective by capturing the right kind of data, passing on the right kind of information. And this is not to say that this hasn't happened already. So, I mean, you would see, and I'm sure all of you would have seen examples. I've personally seen Egypt doing some great work under UHIA at the primary health unit level as well in terms of digitization. So already you know that at a community level, there are community health information systems in a lot of African countries being rolled out, like Uganda, Rwanda, Ethiopia. Saudi Arabia right now is rolling out at a mass scale electronic medical records across all their health facilities in the kingdom. Egypt has done that through UHIA for its primary health units. Similarly, you would see Burkina Faso has implemented community health information systems specifically for childhood illnesses. The medication management has taken a whole new dimension on how you manage supply chain, how you manage pharmacies in certain countries, and certain examples on around with digital healthcare interventions. Similarly, drones are being used increasingly in countries such as Rwanda, India now, to deliver medications in the areas at primary health centers which are very far off or cut off from a usual typical supply chain measures which always existed. Similarly, Brazil, UK, rapid diagnostics, self-testing for HIV, behavioral integration in terms of how can you self-check your symptoms for COVID or certain kind of diseases. That has been done at a primary healthcare level in South Africa. So overall, we do see a lot of innovations. We do see a lot of work happening at a primary healthcare level at a digitization, from a digitization perspective. But I think what's probably missing right now is that how can we get it into a roadmap to create a comprehensive view of what the new primary healthcare system from a digitization perspective should look like. So what's that roadmap that the countries are trying to achieve, so that we don't limit ourselves to some ad hoc or some certain interventions which are programmatic or very specific to one disease, but we actually work at strengthening the whole system using this digitization. And that's where I think a lot of focus now countries are bringing towards. There are a lot of successful examples in countries which are doing it. So it's best to learn from them. But it's more important that the country builds a roadmap for itself to say that, okay, these are the 10 things that I need to digitize at a primary healthcare level, and this is my priority, and this is the roadmap that I would take over the next 3 years, 5 years. And obviously, when it comes to digitization, there are always certain okay, before I get into that, there is actually studies. So obviously it increases effectiveness. But if you would also see, there has been a study recently that if a healthcare system is fully digitized, then it can actually create a savings of roughly 15% in its healthcare costs. So it's not just about, while obviously digitization needs investment, you need to put in money for digitization, but in a way, in a long term, that money pays itself off by ensuring that there is more efficiency in the system. And some of the digital health tools which have kind of shown the maximum value are things such as telemedicine, virtual interactions, electronic medical records, how can you get e-prescriptions in place, the digital diagnostics that I spoke about. So I think the core point of this is that it should be seen as an investment which will reap returns rather than as a cost which will increase the cost of healthcare in the system. And obviously there are apprehensions. We know that while there have been experiments which have gone very well and very successful in digitization, but each one of us has also seen experiments which probably haven't given the result or haven't gone that well. I think few of the considerations that should be kept when going towards digitization is that it can potentially create a digital divide. So there is an online population and there is an offline population in most of our countries, people who do not have access to mobile phones, even simple mobile phones. So how do you ensure even they have control of their healthcare data and their healthcare records? And how do they still own their own information and get the consent? So that becomes very important. The privacy and security concerns are obvious. While the technology has really moved very advanced, wherein there are a lot of, I would say, systems which can ensure that privacy and secrecy is not compromised at all. But once again, a conscious effort has to be there to put together the right kind of laws, regulations at a primary care level as well, to ensure that the privacy and security of the data and information remains of paramount importance. There is also a consideration with the AI coming in, will it replace doctors? Will it replace the physicians? In our view, that is not possible. Ultimately, these have to be seen as tools which allow clinicians, physicians, nurses to operate more effectively, but it's not a tool to replace them. The human judgment always comes first, and that's what it will be. So while it is a great decision support tool, but it's not a replacement, and that can also ensure that there is no misdiagnosis or over-treatment using technology. But one thing, last and final point that I had that we need to guard against is that the whole idea of digital technology is that it should be a barrier to fragmented care rather than adding up to fragmented care. We have seen that's happening, wherein because there is a technology implemented for one certain program, a vertical program, it kind of creates a more fragmented care than actually an integrated care. So the idea is that technology should always work to give a more integrated care, not focused on vertical programs. And even if there is a vertical program technology, it should ultimately feed its data and information into a central system which can enable that integrated care for the population. So yeah, that was the last slide and some of the things that I wanted to highlight before I pass it on to my colleague Shirley to take it forward. Over to you, Shirley.
Thank you, Dr. Deepak. Thank you. And thank you for highlighting the examples of the use of digital technologies from the different countries. Thank you also for alerting us for the need of a roadmap in the context of system strengthening, not just health system strengthening, but also system strengthening as we move towards digitalization and primary health care. And you also brought into a very important point of the need for integration. All of this should be integrated and not create more fragmentation within the system, in many cases, which is happening around. So thank you again, and over to Dr. Ante Becker-Benton, who's the Managing Director of the Behavior Change and Community Health Program, Save the Children US, who's going to speak about promoting comprehensive sex education and youth-friendly services. Over to you, Dr. Ante.
Sabah al khair. Thank you, Shirley. Thanks very much. And thanks to the previous speakers. It was a great start of our panel. As mentioned, I wanted to talk today about the role of social and behavior change in primary health care, including the promotion of youth-friendly services and comprehensive sexual education. I would like to start us off actually with the latest definition of social and behavior change, as this is a very dynamic and fast-moving field. You may have heard of human-centered design and behavioral insights, behavioral economics. These are all part of social and behavior change as a larger umbrella. The current definition per the United States Agency of International Development is that social and behavior change is a systematic, evidence-driven approach to improve and sustain changes in behaviors, in social and gender norms, and the enabling environment. And SBC as the abbreviation. Interventions aim to affect key behaviors and social norms by addressing their individual, social, and structural factors. SBC is grounded in several disciplines, including strategic communication, marketing, psychology, neuroscience, anthropology, behavioral economics, and the behavioral sciences, including sociology. So you'll see that we went quite beyond the beginning of health promotion or message delivery or health education. And SPC these days is based on a lot of lessons learned that it's not enough to address individuals only, but that we need to look at collective action, at community engagement as much. The role of social and behavior change in primary health care is actually quite large and larger than many think. And I think that's the point I'm trying to make today. So SPC activities not only shape demand for accountable, affordable, accessible, and reliable care, but can also address and support the behaviors of all people and organizations within the health system that are essential to the equitable provision of quality care, and that includes policymakers and providers. So beyond demand creation, SPC can shape the correct use of products and services, but also health provider behavior change, couples communication, and community engagement to change social and gender norms and also structural barriers. What you're seeing here on the right side is the Circle of Care model, which has been promoted quite a bit by Johns Hopkins Center for Communication Programs. And it elaborates on the role of SBC before, during, and after care, going beyond health promotion and messaging into how to motivate clients to access services, how to improve client-provider interaction and respectful care, and how SBC engages also in aftercare through boosting adherence and behavioral maintenance, which is one of the most difficult things to do, actually. There is a large role that social and behavior change plays also in community health, which is, again, a large part of primary health care. SPC contributes to improving quality of care by strengthening community health workers and health facility committees, for example, and how to engage with and communicate with communities and households more effectively. SPC helps to mobilize communities for collective action and link them better to facilities, which includes social accountability approaches, such as scorecards or partnership-defined quality. And SPC also mobilizes social support for household health practices using strategic communication and local media for amplification and scale. And this is something often underestimated. It takes a lot of social support for household members to actually try out new behaviors, to change their behaviors in the household, but also in the community. So it's not just, again, an individual level change that we're looking at. There have been slow changes among barriers that adolescents face in addressing primary health care. And one of the reasons adolescents bear disproportionately poor health outcomes is that they face unique barriers in accessing and using high-quality health services. And these barriers include structural barriers, social barriers, and also individual-level barriers. And you're quite familiar, I think, with many of them because they have not changed much over time. For the structural level, there are distance to facility, hours of service, limited capacity of providers to provide information, limited financial resources to pay for services and supplies, legal and policy issues and restrictions. At the social level, we find still a lot of stigma and discrimination around adolescent sexuality, gender norms limiting mobility and decision-making, as mentioned, often negative treatment by providers and health workers, and then there are community attitudes to deal with towards services for adolescents. At the individual adolescent level, there is lack of knowledge of health needs and options. They are fearing being seen and judged. They themselves carry a lot of myths and misconceptions. And there is limited decision-making power, and their agency, their self-efficacy is quite limited at that age, which we, I think, all understand. But the point I'm trying to make is that a lot of these sexual reproductive health efforts are undermined by insufficient attention to underlying behavioral drivers. In general, efforts suffer because key elements needed for sexual reproductive health are well known. Instructors often, while key elements of sexual reproductive health education are well known, instructors often remove content that they are uncomfortable with, and they replace it with inaccurate information because the underlying social norms that stigmatize discussions of sexuality, especially with young people, have not been addressed before. And this clearly limits the effectiveness of reproductive health education and comprehensive sexual education, and further perpetuates the stigma, actually. And similarly, traditional one-off trainings in youth-friendly services are not enough to change social and gender norms among providers. Protocols are often not standardized or not used, and the overall effort is stymied by harsh and judgmental treatment from providers. All in all, social and behavior change could be used a lot more effectively to improve respectful care. But it is important to see that there is a systems aspect. It's not just behavioral, even on the provider side. Providers are the customer service agents in a system that is in many places has failed to ensure adequate staffing, compensation, infrastructure, and supplies. And so those aspects are also important to address to improve respectful care. It's not just behavioral. We need to work together on the structural level as much. This is why, because of these recurring issues that are observed in many countries, including in Egypt, there is a shift away from youth-friendly services to improve the responsiveness of the broader health system to the needs of adolescents and youth. What you're looking at is the change that has happened in 2020 of the adolescent responsive contraceptive services high impact practice. That was a mouthful. And it was updated and includes now the expansion of responsive systems. So what it says is that adolescent responsive health systems refer to making existing health services responsive to the needs and preferences of adolescents by incorporating evidence-based elements throughout all components of the health system rather than implementing isolated interventions. So this basically signals an evolution from traditional standalone models of adolescent-friendly service towards more of a systems approach. And it doesn't say that there is a stop to rolling out adolescent-friendly health systems, but rather to ensure that youth-friendly services are well integrated into the primary care system rather than be implemented as standalone or in parallel. And I think this is especially important for this region because we're talking in American English a lot about youth bulge. So, for example, in Egypt, the under 29 group in Egypt constitutes 62% of the country's population, which means everything needs to be youth-friendly. Now, an interesting part of how youth actually receive their information is something you see on this slide. 54% of adolescents that were asked in a survey run by Love Matters Arabic in 2019 said they received their information from friends, 58% internet and social media, only 37 mentioned school. And when asked whether they felt comfortable asking their teachers about sexual reproductive health information, 60% of youth said no. That doesn't mean that comprehensive sexual education should take place in schools, but it means that teachers have to be very well trained. And I think overall, this shows that we need to look at a multi-channel approach. So not just one thing, not just youth-friendly services or not just comprehensive sexual education, but kind of a multi-channel approach to address these issues where, youth basically receive their information, which information they trust. And hence, I'm coming to my last slide. A recommended set of interventions is the one that you're looking at. A clear recommendation to not put all eggs in one basket and to either offer sexual reproductive health education or youth-friendly services, but a comprehensive set. In Egypt, the groundwork for comprehensive sexual education has already been laid through community engagement, alliances with religious groups, and a wealth of resources and lessons learned from previous programs. It depends, however, very much on the quality of implementation and training to be able to positively impact this current and future generations in their awareness of sexual reproductive health and rights, gender-based and sexual violence, and family planning methods. Also in Egypt, there are currently around 2,000 youth-friendly clinics distributed along 27 governorates. However, not all these services are offering a private room for primary health care and are following a unified protocol. And currently, the OSRA project that I'm also supporting is cooperating with the sector to prepare a training program for physicians and nurses to address youth needs and demands more comprehensively. What is also important is to increase health worker training, to add more intensity, to continue to work on social and gender norms at community level is a critical way to overcome barriers and resistances. And there are 2 other evidence-based interventions to engage adolescents and adults directly. And those are small group activities and interpersonal communication through home visits, social and mass media. These are all important to build not only knowledge or deliver messages, but critical life skills, improve attitudes and behaviors, and again, social norms towards gender and sexual reproductive health. So I'm coming to an end with this presentation. As a takeaway, the role of social and behavior change in primary health care is underused and could help to achieve sustainable change goals, not only for adolescent responsive health systems, but also for parents, providers, and communities. Thank you very much.
Thank you so much, Auntie, for your presentation and for highlighting the importance of the role of SPC in primary health care. So we now go to Dr. Rondi Anderson, midwifery expert from UNFPA Syria, who will be speaking on midwifery as a best practice to improve reproductive health. Over to you, and Rondi.
Thank you. Thank you to the organizers of this conference. It's been very interesting to be here, and to my colleagues on the panel and to my colleagues in the audience and all of you that are here. So midwives. We have a goal to save lives, to improve health, and to empower. We talk about this survive, thrive, and transform. How do we move women into our healthcare systems and have them leave stronger and more confident? Certainly, our goals within sexual and reproductive health include that obstetric and newborn emergencies be managed and they be managed efficiently, and that women get the care that they need to be able to survive, and so that we can meet the sustainable development goals and maternal morbidity and mortality falls. We also, and this is true everywhere globally, we need to shift more toward a quality standard. That we have very clear WHO guidelines, and in almost every healthcare system there are gaps. So how do we move toward quality and respect within maternal health care and sexual and reproductive health care? And of course, this ties into rights. How do we find that gender transformation? How do we make sure that, that women get what they need? And one of the things that many countries are struggling with is how do we reduce unnecessary interventions, and often highlighted through cesarean sections, but there are others as well. And how do we ensure that comprehensive sexual and reproductive health care is available to everyone at the primary health care level, at the tertiary health care level? These things like family planning is accessible. On the first day, there was a lot of conversation about how do we reduce population size? And of course, it's about choice, but it's also about availability and how do we make sure that it's available for everyone. But in addition, health response to sexual violence, sexually transmitted infections and HIV, cervical cancer screening and pre-cervical cancer treatment, adolescent reproductive health care like my colleagues talked about. How do we ensure that availability all the way down into the community? And then one of my latest ways of thinking about it is, what if we put on glasses where all we could see when we walked into a healthcare system was how does the woman feel? And we know that there's many gaps if we look at it from that perspective. So what are the human resources for new and improved healthcare for women? What do we see as the components of what that human resource should look like? So we know that she should be globally standard, and we have global guidelines. The International Confederation of Midwives is a really good source that has lots and lots of standards. They just came out on one for enabling environments, but they also talk about what do we need in terms of ensuring competence and confidence. We want them to be dedicated. In terms of women's health care, if you've got the same person on the men's ward working with TB and pediatrics, and then she rotates into the maternity ward, probably she's not going to have the expertise that you need. You want her to focus in on this important area. You want her to be enabled so that when she comes to work, she is empowered to do what she's competent at, and she can work fully. And you need to monitor, because what we know is that as strong as we can get our vision to be, when we actually implement it, inevitably there will be gaps. So we need to set up monitoring systems. Now, many people wonder, if we just had the resources, wouldn't doctors be the best? And that's actually not what we're seeing in the literature, that in fact doctors are busy, that we have many examples of doctors seeing over 70 patients a day when we have other healthcare providers that might be able to take some of that load, and over a certain amount of busyness, no matter how strong they are, the quality will fall. Also, we tend to have higher concentrations of doctors in urban areas, and the most remote rural areas have a harder time being reached. In addition, although I have been very grateful for doctors a million times in my life when I worked as a midwife, they are experts in complications. So if you've got an emergency, you want a doctor there. But in terms of respectful care and quality care, it's a lot of hands-on. And oftentimes doctors are more focused on the medical treatments and less on how do we make sure that the woman has a companion with her and that the baby is skin to skin. And these kinds of things that healthy, normal women need in order to have the best outcomes might not always be what a doctor's focus, what they want to focus on. And unfortunately, what we see in a medical-based care is that we see these increased cesarean section rates. And what the literature shows is that health outcomes are about equivalent with a professional midwife and with a doctor, but for low-risk women. For high-risk women, it's something very different. But satisfaction rates are less, actually, with a medical model. And I sort of touched on this, but are nurses and midwives the same person? Can't we have just one person that does all of nursing and all of midwifery? And again, I'm sort of repeating myself, but it takes an expert to bring about real change. And I mean, depending on your context, oftentimes this bringing in the latest WHO guidelines in terms of sexual and reproductive health care is a handful. I mean, you have to learn this new standard of quality, all these new evidence-based care things. We've got a woman upright and making sure there's postpartum contraceptives. They've got to be able to manage a postpartum hemorrhage and know how to manage eclampsia, at least the initial stabilization. And then all new techniques for reducing these interventions, and then how to respect and empower. So it's really quite a plateful for just sexual and reproductive health care. So this is what we're seeing recommended in the literature globally, this midwife-led model of care. And that first, the lead professional for planning, organizing, delivery of care from the initial antenatal visit through postnatal care, including the intrapartum period, that comes off of the International Confederation of Midwives website. But that is what's being recommended, that it's women-centered, that midwives are experts in the normal, but they can provide the initial stabilization for emergency, so they can save lives, and they're part of interdisciplinary teams, that midwives very much need the team in order to be able to ensure that women get what they need. Now, I just pulled this morning off of Google Scholar, so this is not at all comprehensive or representative, but you'll find that there's lots and lots of literature, some from WHO, from Cochrane Database, highlighting the safety of midwives, and there's also a lot of literature talking about what they need and what can constrain them and how they might not fully be able to realize their potential if they don't have the enabling environments. And just quickly, a few slides to look at what do we need to do to introduce midwives. And this is what the International Confederation is talking about, this midwifery philosophy, which is essentially the quality of care and rights. And we need gender equality, we need enabling environments, leadership, we need ongoing research. This midwifery-led care model, we need our education up to standard, we need regulation and vision, we need association, which is essentially voice. And then also through the eyes of the UNFPA that I work for, which is, I'm not going to read this to you, but it's a very similar kind of model. Midwifery workforce being highlighted here. But what do countries need to think about and take into consideration if they're going to effectively introduce midwives in order to make a change in their health systems? And this is from the State of the World Midwifery, which if you haven't seen it, it's worth looking at it. But again, some suggestions for countries in terms of where to put their focus, and you can see that there's a lot of overlap. And I'm just going to dive in a little bit in terms of this regulation strategy policy. Don't underestimate the importance of this. This is essentially a vision of what do you want it to look like when you're done, and then writing the recipe of how you're going to get there. In order so that in future years, people know exactly what to do and they don't get off track. I mean, I put dedicated posts up there. I could tell you a lot of different examples of things that countries have done, and then they all of a sudden realize, oh geez, we've got a gap. Like you educate your midwives, but then you don't have any posts for midwives. And of course she can't be effective if she doesn't have a post, or if she goes into a nursing post and is on the pediatric floor. So these, at the policy level, at the regulation level, what do you need? What does a country need in order to make it be most effective? And then just a little bit about education. The basic education for a midwife is 3 years post the 12th higher secondary education, or 18 months post nursing. It's the ICM gives us really clear guidelines. We need to focus on classroom, simulation, and clinical teaching. And simulation is, of course, more than just having the mannequins. You also need to have educators that are very comfortable with simulation, and sometimes you need some staff for your simulation labs to make it happen. Accreditation is very stressed right now, and so countries need to be thinking in terms of what would the global standard look like coming into our education facilities? And of course, e-learning. I mean, to piggyback onto what Deepak was talking about, but there's huge e-learning potential, both for pre-service education and also for in-service education. And again, enabling environments for midwives. We have a lot of recommendations in terms of quality, that standards for improving quality, that's WHO, and then again, prevention of and elimination of disrespect and abuse in facility-based childbirth. So really, maternity care kind of runs the gamut of almost crossing into a harmful, like the potential for harmful behavior in maternity care is there, and we see it over and over again, and there's all kinds of examples, all the way to being able to be transformative and empowering. So how do we maximize the use of our midwives? How do we make sure that they have professional status and agency, that they're integrated into the existing systems? And just like a few examples from my experience, that it's very important that the managers are oriented right from the start, so that you have everybody on board. And I would, of course, we include the doctors and nurses teams, but also the professional organizations, so that when you're introducing midwifery, everybody who's overseeing maternity care and comprehensive sexual and reproductive health care is very much on board. Just some models of success. We know that these Nordic countries tend to be have the best outcomes. The maternal mortality rates are great, and most of them are using over 75% midwives. They've got the lowest cesarean section rates. But many other countries have successes. I've worked recently in Bangladesh and Syria and Rwanda, and all those countries have good successes. In the United States, where I come from, although midwifery-led care is not the predominant, but we are strong, and we have very good examples of good outcomes. And this is just a reminder in terms of how to monitor, like once you roll things out, that this is a dashboard for a country level survey to look at how are you doing in terms of government and leadership, and what activities have you got implemented, and how are they going, and in terms of the different themes that we saw in the earlier slides, regulation and association, enabling environments and research. It's just one example of how countries might look at how are we doing. Thank you very much.
Thank you, Dr. Rondi. Thank you so much for highlighting the importance of respectful and quality care, which is really important. And you also highlighted the importance of the high impact interventions that we really need at the community, at the PHC, at the community level, especially in terms of the skin-to-skin care, the kangaroo mother care, which is known to show how many lives have been saved in the countries, especially in the emergency context and the humanitarian context, where we do not have a strong primary healthcare system. So it's also important that we keep these important aspects in mind as we move ahead with strengthening our systems. So we are at the hour right now. It's already 10. So just give us 5 minutes, just one key takeaway from each speaker. So over to you, Dr. Bernardo. 30 seconds to you.
Thank you. And I would just highlight the importance of strengthening primary health care. There's a health argument which is very evident. It's much more efficient to invest in primary health care and achieve better health outcomes. There's an economic argument, which I mentioned, about enabling the population to be healthy, helps the economy, helps social development, and has many other positive externalities. But in Chile, we're also very concerned about the social identity argument. I mean, what does it mean to be Chilean? What does it mean to be Egyptian? We have mountains, you have pyramids, that's very well. You have a rich history which might identify your population, but when somebody gets sick, how does the society take care of that person is a fundamental issue that builds what we understand is our identity, is our nation, and I think primary health care can also be a solution for that national identity building. Thank you.
Dr. Deepak?
Is it working?
Yeah, it's good.
Yeah, okay. So I think I'll go back to the point I made during the presentation around the interoperability and the integration when it comes to technology. And I think there are now cases such as India. I think if you have time in the audience, go back and study how India is building the whole national digital health mission. They took 6 to 9 months to just set the right standards. How will they engage with the private sector? How will they go about setting the right interoperability? And then the whole implementation becomes a lot easier. So setting up the right kind of roadmap with the standards driven and interoperability being the focus is probably what the digitization should look like. Thank you.
Thank you, Dr. Deepak. Over to you, Dr. Antil.
Thanks for that. Yeah. I think I'm repeating my key point that social and behavior change is underused in primary health care. It can be applied to the circle of care which you've looked at. Before, during, and after. And I would like to give a shout out to my colleague Hannah Banat, who is working for the OSRA project and who I am supporting at times. She has done exactly that. She has developed a demand creation and SPC strategy that focuses on the 3 stages of service interactions, the use of SPC to motivate clients to access services, to improve the client-provider interaction during services, and to boost adherence and maintenance. So please, if you meet her at this conference, Hannah Banat, you should ask her more about her work at the OSRA project in Egypt.
Thank you, Dr. Anti. And over to you, Dr. Randi, over to you. Just one key takeaway.
Thank you. Midwives are a good idea, but in order to get the most out of them, you need a comprehensive vision and a focus on all the stakeholders and on effective enabling environments and implementation.
Thank you so much, and let's give a big applause to the panelists this morning, and thank you very much for listening to us. Thank you.
Thank you, sure.
Yes.
Thank you so much for this panel. The next panel for today, entitled Public Health, Ensuring Healthy Lives and Promoting Well-Being for All. The panelists for this panel are Her Excellency Professor Maha Al-Rabat, former Minister of Health and Population, Egypt. Dr. Farouk Shamas Jiwa leads the MENAT region team Organon. Dr. Muhammad Ahmed Al-Jarallah, Senior Bariatric Surgeon, President, Islamic Organization for Medical Sciences, former Minister of Health, Kuwait. Dr. Naima Al-Jasir, World Health Organization Representative, Egypt. Ms. Paula Barbarino, CEO, Alzheimer's Disease International. And the moderator of this panel is Dr. Selina Bajraktarevic, Chief of Child Survival and Development, UNICEF ECHO.
أنا لما هتكلم هطلع أتكلم هناك. So I have 7 minutes, yes?
Yes.
Or 10.
7.
Sorry, Farouk, Stuart, nice to meet you. Sorry we didn't have a chance to connect.
There's a clicker for the presentation. If you're going to present from the podium, you're going to press next or back to change the slides.
I have a video embedded in my presentation. How do I play that?
Yeah, sure. That will press next and the slide of the presentation will play later.
Okay.
مرحبا.
Thank you, guys.
Presentation present. Next to that, right on the slides.
Good morning, everybody. It is my great pleasure to be here with you and to greet you. My name is Selena Bayraktarovic, and I'm coming from UNICEF. It's my great honor to be here this morning to moderate this session. I would like really to express sincere thanks and gratitude to the Ministry of Health and Population for giving me this honorable task. This panel will talk about the public health, ensuring healthy lives and promoting well-being for all. This is an extremely important topic, and my distinguished panelist and expert will talk about the following objectives: effective public health strategies for health promotion and disease prevention, major global and regional public health priorities, interventions targeting major public health challenges, including non-communicable diseases, infection diseases, health inequities and disparities in changing world, showcasing public health programs and initiatives promoting health equity, reducing health care inequities, and population health outcomes. And the last but not least, alternative care solutions for improved health and well-being of older adults. We have 1 hour, and I would like, before we start with the 4 presentations and our honorable and distinguished keynote speaker, I would like just to present to you the panelists. Her Excellency, Professor Maha El-Rabat. She is the keynote speaker. She is the Professor of Public Health, Faculty of Medicine, Cairo University. She was the former Minister of Health and Population in Egypt. Dr. Farouk Shamasjiwa leads the regional team Organon, and he will be also talking about his experience. His Excellencies Professor Mohammed Ahmed Al-Jarallah, Senior Bariatric Surgeon, President, Islamic Organization for Medical Science, and former Minister of Health in Kuwait. Her Excellency Dr. Naima Al-Gasser, Director of WHO Egypt. Professor Paola Barbarini, CEO Alzheimer's Disease International. After the keynote speaker note and the 4 presentation, we will open the floor for your questions, and we will end these questions with some concluding remarks. Thank you very much, and without further ado, I would kindly ask Professor Maha to give her speech.
Well, thank you. صباح الخير جميعا سعيدة ان انا موجودة مع حضراتكم، وسعيدة ان انا بشارك في البانل المهم دهوت. وبشكر المنظمين طبعا، وبشكر وزارة الصحة والسكان على هذا المؤتمر وعلى الموضوع المهم جدا اللي بيتناقشه الكونجرس دهوت. Thank you very much Dr. Selina, and thank you very much for the introductions and for the panelists as well. So I'm going to give the keynote speech in 7 minutes, so a little bit more concise and a little bit more quick, but opening the floor at the end for discussions or for questions and answers is going to be an opportunity to further explain some other things. So at the very beginning, I would like to say that ensuring health, lives, and promoting well-being, which is the issue that we are discussing now today, is for all is the focus of the Sustainable Development Goal 3 of the 2030 Agenda. But at the same time, if we look at this Sustainable Development Goal, we're going to find that it is addressing the major public health issues through the 9 targets. So this is a comprehensive range of health priorities. If we are talking about the sustainable protection of the lives and the well-being of each and every one, so there is like an inclusiveness of leaving no one behind. And at the same time, it grasps many of the already spoken about universal health coverage, the well-being, the equity, and. So in itself, it really encompasses many of the priorities that we are talking about. So it addresses the maternal mortality, infant non-communicable diseases, environmental causes of ill health, substance use and abuse, road traffic accidents, access to sexual and reproductive health, and achieving universal health coverage. So, and as well, not only this, but it calls for research and evidence-based data, and in order to be able to formalize all this into an actionable and strengthened capacities as well for harm and health risk reduction. So if we're talking about this, we find that the definition recognizes a multilateral, multi-level nature of health and well-being. So we're not talking only about health, but we're talking about the multi-leveling of it. And the multi-sectorial, everything is there, so they strongly influence the well-being and the health. So the terms health and well-being, they describe separate, but they are interrelated states. Health influences well-being, and conversely, we find that the well-being is influenced by health. So it incorporates physical, mental, but as well the well-being which incorporates the social and other environmental complexities that, or structural complexities that really, and an outcome of health. So in itself is a determinant of health, but as well, according to the SDG, it is an outcome of health, and it needs to be measured in a way to be very objective and not subjective. So ensuring healthy lives and promoting well-being describes a vision. And I'm always talking about the vision, the oversight. How do we look at it, and where is the focus? Where is our true north when we're talking about ensuring healthy lives and promoting well-beings? This is a vision which is described in a way towards a goal of inclusivity for all people and across the lifespan. If we all have this vision, then definitely we're going to know what is the role and responsibility of each and every one of us on the professional level, institutional level, and on the community level as well. And to be achieved, to reach out or to reach to this vision, we need interventions, we need policies, and extend beyond the health sector. So the collaboration and the multi-sectorality should be there, and it should be strengthened in a way to achieve the vision. We're all looking and we're all having this same vision. So they extend to engaging characteristic of an expanded and diverse array of users, disciplines, sectors. All of them, they are into one package that will achieve this goal or this vision of health and well-being. So we're talking about as well issues that really goes far beyond to the mental health part, to the housing, the education, the business, the aging. All of them, they are characteristics for the expanded and diverse array of users. So gaining such benefits if we're talking about the health and well-being and the structural complexities and all those determinants, gaining those benefits requires eliminating the disparities, which leads to inequities and leads to unfairness, including the health inequities and the affection of the vulnerable groups. So all the sectors, they need to be there to remedy such disparities. So it's not only the work of the Ministry of Health, we need to go beyond this and expand to the other sectors for achieving this. For resources. And resources are really needed, and when we're talking about resources, we're talking about a dynamic environment where the resources, they need to be sustained at a certain level in order to be able to work on it, and the determinants of health, they must all be addressed at all levels. There is a dynamic mix of resources that are needed, and they are need to be thought of strategically in a way from one point leading to the futuristic outlook of where we want to be and how to achieve it. So we know that action might be costly, but the cost of inaction is really much more great, where millions of people can die, where millions of children can be affected. So, and not only this, the elderly and all of the dynamic situations that is really affecting or leading to the complexities of the environment. So we know, let's say that non-communicable diseases alone will cost low and middle income countries an extra of $7 billion a year in the next 15 years. So these are things that need to be worked on, not only in terms of treatment, but in terms of promotion and prevention. And this is where the vision is really important when we're acting on the well-being and inclusivity. So I will not, I would just want to mention one point, Dr. Naima, and I hope it does not affect what you're saying. It's the challenge of equity and equality. So in the target 3.8, it seeks to achieve universal health care, but says relatively little about the pathways by which it should happen. At the bottom of the most socioeconomic ladders, so inequality is not only economic, but it is reinforced by such factors such as gender, stability, disability, people movement, and these are things that have to be considered. So approaches are needed in order to unpack these different root causes of inequality and unfairness, and how they interact together and interact with each other, and they provide these fundamental differences in the ways in which different groups interact. So where are we now? And this is really very important, and it's going to shape our vision and the oversight that we should all be sharing together. So we have witnessed remarkable progress over the past decades. Increased life expectancy, the school enrollment, education, improvement in the transportation, reduction of child and maternal mortality, the new number of cases of HIV/AIDS, of malaria, of tuberculosis, improved the wash, the drinking water, the housing, the sanitation, and we may have come a long way, and we have come a long way, but we still have a longer way to go. This is a dynamic environment, and we need to be on top of all the changes that are expected and predictable to occur. So we need to have a futuristic outlook. Achieving the vision in the coming decade will require working at different levels, different sectors, and coming together. So the governments, they need to embrace innovative ways of thinking and widespread systems innovation to make real progress towards a healthier and more prosperous world. At all levels, as I mentioned before, to strengthen the multi-sectoral collaborations. And to guide reaching this vision in the health agenda and strategy, we need to guide the directions of resources, generate data, evidence-based interventions, and activities that are set to apply at the national and sub-national level. So contextualization is really important. There is no one size that fits all. We need to be more strategic in the way that we are following. Creating the political will is very important, and fortunately in Egypt at the time being, the political will is very high to achieve for the health sector and for the well-being and the social prosperity of the communities. And the actions for prevention and promotion of health require programs with visible commitment to dedicated and specific public health efforts. And here comes the importance of the public health. Where is it placed within the health system and within the strategic follow or pathway? The disease control and environmental hygiene environment, programs, the work, and all of this need to be strengthened. We need to be policy coherence, application of data, technology, partnerships, and health systems resilience building. We need capacity and capability to develop initiatives that can keep up with continuously changing social contexts, geared towards a hard new social and economic development model that addresses the many challenges that are there and that are expected and predicted to occur. And many of them are happening and could be happening in the formation on humans and planets at the same time. And it provides a deeper understanding of the different types of transformations designed to serve people and the planet. So they are treated as one in one package and one basket. One of them is affecting the other. So we're talking and transforming to the well-being.
Very much. Our next speaker is Mr. Farouk. Please, floor is yours.
So, Your Excellencies, distinguished guests, colleagues and friends, thank you so much for the opportunity to be here and to speak to you about Organon, the company that I represent. Organon, actually one of the main questions that I get about Organon is, what is Organon? Who are we? I'll walk you through some of the presentation talking about who we are, as well as some of our perspectives when it comes to our primary goals and objectives. If I leave you with one message in this presentation, it's the following. Investing in women's health is one of the most significant returns on investment one can make. It is transformative, it is rational, it is equitable, and it is critical to break the barriers to health created by a male-dominated health system that has been in function for decades. It is that women are at the center of everything that we do. And our vision is to create a better and healthier every day for every woman. We believe that healthy women are the backbone of a thriving, stable, and resilient society. And why? Because when she's healthy, she's empowered, she's resilient, she prospers. And when she prospers and when she is healthy, her family prospers, her community prospers, her society prospers, and the world prospers. Just a little bit about our global reach. We have a portfolio of about 60 medicines and products across various therapeutic areas, 10,000 employees, and one of the most proudest statistics that I like to share is that 70% of the board of directors in our company are female. This is the region that I represent, the Middle East, North Africa, and Turkey region, from a policy, communications, and market access perspective. We're a very dynamic region, and one of the things that we like to say is that we work as a cluster. We work in 48 countries, and the lessons that we learned in some countries are applied to others. So for example, in the case of Egypt, where we have a lot of political will, as was just mentioned, and a lot of promise around women's health, this is something that we take to other countries and to ensure that they also learn lessons from what's happening in Egypt. So I mentioned women's health. Other areas of our work include biosimilars and established brands. But what I really want to focus on is women's health. And we're fearless, I believe, in our commitment to deliver innovation, improve access, and expand choice. Since our inception about 3 years ago, we started with around 3 major areas: family planning, fertility, and breast cancer. And through acquisitions and through our innovations have had the addition of postpartum hemorrhage, preterm labor, endometriosis, polycystic ovarian syndrome, and bacterial vaginosis. Why? Because we believe that everything that we do begins when we hear her voice. And when we hear her voice, it directs us to where we need to go. Hence our pipeline that we are building towards advancing women's health care. This is another statistic that I like to share. Only 4% of global R&D focuses on women's health. I'll repeat that again. Only 4% of global R&D focuses on women's health. When we compare it to the wider sectors in healthcare, we must admit that this is a paltry sum when it comes to focus on over 50% of the world's population. One other area that I want to talk about is gender-sensitive policies, because it's quite clear that when we integrate gender considerations into interventions, this has a health outcomes for all, as I mentioned before, impacting not only women, but overall societal health as well. But more research and more data needs to be done, and more investment needs to be done when it comes to investing in women's health. Gender-sensitive policies allow for positive health outcomes, and especially for a family. And I know that my UNICEF colleague on the panel is quite keen about children as well, because it's very important that when we invest in in women, we're also investing in the children who are the future generations of the world. So what are some of the measures that we can take to ensure that women's health needs are recognized? First and foremost, as I said before, we need to recognize that women's voices are heard. When we started out as a company, when we listened to women and where we were going, one of the interesting things that came out, apart from what I've already shared, is that mental health became a top priority. I must say that as a new company, this somewhat surprised us as a pharmaceutical company, because we realized that we are focused on the science and the medicine, but we have to take a holistic view at the end of the day on what women want. And so from that perspective, and especially in a post-COVID environment, it's very clear that we're taking these issues to heart. Women's health, making it a country priority and putting it on the national agenda is